This presentation will examine the neurological condition botulism, its pathophysiology, signs, symptoms, and diagnosis methods, its effects on motor control, and the treatment options currently available. Botulism is a rare neuroparalytic illness caused by exposure to the toxins produced by bacterium Clostridium botulinum. Clostridium botulinum is an anaerobic, gram-positive, rod-shaped bacteria found naturally in soil, silt, and the intestinal tracts of some mammals. When under stress and in a warm, moist environment with adequate protein stores, the bacteria develops toxin-producing spores. These toxins are nerve inhibitory and are what causes symptoms of botulism. There are three main types of botulism: intestinal, foodborne, and wound. Both intestinal and foodborne botulism are caught from eating food containing either the bacteria or the toxins produced by the bacteria. Wound botulism occurs when the Clostridium botulinum enters the blood directly via an open wound or needle stick site. There are 7 distinct forms of the botulinum toxin, of which are labelled A to G and are differentiated by the antigens they have on their outer surface. Only toxins A, B, E, and sometimes F are capable of causing illness in humans. The active form of these toxins consists of a 2-chain protein composed of a heavy-chain polypeptide and a light-chain polypeptide joined via a disulfide bond. Botulinum toxins act at the presynaptic motor neuron terminal, inhibiting the release of acetylcholine by cleaving key snare proteins required for nerve activation. The toxin binds to the nerves at the acetylcholine site, triggering the neuron to take up the toxin into a vesicle by receptor-mediated endocytosis. The vesicle then acidifies, activating a portion of the toxin, which causes it to be pushed across the vesicle membrane into the cytoplasm. The toxin cleaves the host protein, stopping nerve signaling to the motor neuron. The nerve is thus unable to stimulate muscle contraction, resulting in symmetrical flaccid paralysis. When nerves of the respiratory system are affected, respiratory paralysis and distress may ensue, potentially eventuating in death. In adults, botulism first presents as blurred vision, fatigue, and difficulty speaking and swallowing. Digestive issues may also be present in the form of stomach pain, vomiting, and diarrhea or constipation. In infants, botulism is characterized by a weak cry, a loss of appetite, difficulty breathing, and reduced movement and support of limbs. This is also referred to as floppy baby syndrome. Patients with botulism do not have a fever and are not affected cognitively by the illness. As the illness progresses, flaccid paralysis and difficulty breathing will become more pronounced. Diagnosis of botulism is usually made on the basis of signs and symptoms of the patients and then confirmed using medical diagnostic tools. The effects of the botulinum toxin on motor control are the most notable symptoms of the illness. The toxins begin by inhibiting the excitation of the muscles supplied by the cranial nerves. This results in double vision, eyelid drooping, lack of facial movement, and issues with speaking and swallowing. Inhibition of acetylcholine at the presynaptic cleft may also disrupt the autonomic nervous system, yielding dry mouth and throat, postural hypertension, and constipation for the patient. Muscle weakness then progresses in a symmetrical distal fashion, causing flaccid paralysis of each of the limbs. In severe and untreated cases, botulism may lead to the reduction in movement of the respiratory muscles, bringing on difficulty breathing, respiratory failure, and excessive amounts of CO2 in the brain. For this reason, botulism is fatal in 5 to 10% of total cases and 40 to 50% of untreated ones. The main treatments of botulism are antitoxin therapy and supportive intensive care. Passive immunization using botulinum antitoxin treatment is ideally given within 24 hours of the onset of symptoms. The antitoxin consists of antibodies that neutralize the botulinum toxin by preventing binding to the neuromuscular junction. Patients should be isolated and admitted to intensive care immediately, and in some cases, mechanical ventilation may be required for up to 8 weeks. Surgical intervention is often used in the treatment of wound botulism, where the infected skin is removed and the area is treated. Contaminated food in the digestive system may also be manually removed in some situations. Physiotherapy and exercise prescription are used both during treatment and as follow-up treatments to prevent long-term paralysis. The main exercises prescribed are breathing exercises, RUM exercises, and strengthening exercises. To help prevent intestinal and food-borne botulism, it is important to ensure that food is correctly stored and cooked thoroughly. Steering clear of food containers which appear damaged and bulging may also help, as this may be an indicator of the gas produced by the bacteria. It is recommended that parents should avoid feeding honey to children under the age of 1, as this is the cause of infant botulism around 20% of the time. Wound botulism can be prevented in most cases through adequate needle hygiene and use and sanitary wound care. A vaccine is not currently available, however there is ongoing research into its development.